Hi, I'm Conrad Fisher, Associate Chief of Medicine for Education at SUNY Downstate School of Medicine. Come and see us in Brooklyn. Also, don't forget that there are a lot of interesting things to look at the website for Kaplan Medical, and CAP Test. If you like the methodology of which we go through the procedures here, what's the most likely diagnosis? What's the best initial test? What's the most accurate test? What's the best initial therapy? There's a whole series of flashcards constructed along these exact ideas. In other words, if you want a set of flashcards that says, here's this diagnostic test, what is it and when is it the answer? Here's this diagnostic test, what is it and when is it the answer? Cryptococcal antigen, when is it the answer? They show me a guy with AIDS and meningitis and low T cells. That's when it's the answer. CD55-59, also known as decay accelerating factor. What is it and when is it the answer? It's for a guy who's got paroxysmal nocturnal hemoglobinuria. Look for this case, here's the answer. Osmotic fragility, what is it and when is it the answer? Most accurate test for hereditary spherocytosis. So go to CAP Test or go to the bookstores and find these interesting flashcards, and that's how you get me in a box. How would you get Conrad Fisher in a box? Well, the answer is you could do one of two things. One, you can go to the bookstore and get those flashcards. Number two, you can go like this. Here, it's me, I'm in a box, let me out. Well, our next section is head and neck infections. Now, head and neck infections is basically sinusitis and otitis. Now, sinusitis and otitis has the same organisms. It has the same bugs. So therefore, it's going to be the same drugs. Same bugs, same drugs. Same bugs, same drugs. In other words, 40% of the time, it is going to be strep pneumonia, 40% of the time strep pneumonia, 30% of the time it is going to be Haemophilus influenza, 30% of the time it's going to be Haemophilus influenza, 20% of the time is going to be Moraxella, also known as Mozzarella buggeralis. 40-30-20, 40-30-20. Now, what is the radiologic test for otitis media? And the answer is, well, there is no radiologic test for otitis media. So since there is no radiologic test for otitis media, our diagnosis has to be based on a physical finding. What is the most sensitive physical finding for otitis media? Since there is no radiologic test, it has to be based on a physical finding. So what is the most sensitive physical finding? And the answer is immobility of the tympanic membrane. You can have otitis without redness, without bulging, without pain, without diminishment of the red reflex. However, you can't get otitis media if your otitis media, if the tympanic membrane is fully mobile on insufflation. The most sensitive physical finding is immobility of the tympanic membrane. Now, sinusitis. We have a 30-year-old guy who's got a yellow-greenish nasal discharge. A yellow-greenish nasal discharge. Fever, headache, face pain, teeth pain, decreased transillumination, fever, headache, face pain, teeth pain, decreased transillumination. What is the best initial test? What is the most accurate test? What is the best initial therapy? What would you like to do next in the management of this patient? Here are our questions. Here's the history and the physical and the labs. What is the most likely diagnosis? What's the best initial test? What's the most accurate test? What's the best initial therapy? And all of these questions can be answered with, what would you like to do next in the management of this patient? What would you like to do next in the management of this patient? 30-year-old guy with yellow-greenish nasal discharge. What is the most accurate diagnostic test? Most accurate is not a CT, not an MRI, not an X-ray, because X-rays and CTs and MRIs can't tell us what the organism is. Oh my God, I've been looking at this CT scan for an hour and I still cannot see the microorganism. I've been looking at this CT for an hour and I still cannot see the Mozzarella buggeralis, the strep pneumonia. No matter how closely you look at a CT, you cannot stain a CT. You can't culture an MRI. You can't get sensitivities on a nuclear scan. So that means that the most accurate test for any infectious disease always has to be the one that gets you a culture. So what would you like to culture, meine Liebchen, ja? What part of the anatomy would you like to culture? You see yellow greenish nasal discharge, yeah. I bet you want to swab my nose, don't you? I bet you want to touch my discharge from my nose. But the answer is, don't do it! Don't! Don't culture that discharge from the nose. Because you know what? The discharge from the nose doesn't tell us what's inside the sinuses. It's contamination. Look, I'll prove it to you right now. Here, cameraman, come here. Ready? See? You can't tell it's what's in my sinuses. You can't tell it's within my sinuses. You can't tell that it's in my sinuses. The only way to tell what's in the sinuses is to biopsy or aspirate or put a needle into the sinuses. Most accurate, sinus aspirate, sinus biopsy. What's the best initial test? Well, an X-ray is good. A CT is probably better than that. MRI is better than that. But the most accurate test is a biopsy. What's the most accurate test for otitis media? Immobility of the tympanic membrane. Now, since they have the same bugs, they have the same drugs. Now, lo, in the beginning the world was without form and void, and then there was amoxicillin. And amoxicillin is still the best initial therapy for otitis and sinusitis. Now, what about amoxicillin clavulanic acid? Well, that has a broader spectrum. It expands the gram-negative coverage, and it also adds staphylococcus. But amoxicillin is the best initial therapy. Well, what about macrolides? Azithromycin, clarithromycin. Azithromycin, clarithromycin. Well, azithromycin, clarithromycin cover atypical organisms too, like Mycoplasma, Chlamydia, and Legionella. Mycoplasma, Chlamydia, and Legionella. Now, that word atypical is not a great word. It basically means this. When you see the word atypical, it means not visible in a gram stain and not detectable in regular bacterial culture. Not visible in a gram stain, not detectable in a regular culture. That's all atypical means. Because typical means you see it on a gram stain and you see it in regular culture. So that word atypical is not a great word. It'd be better to say, I don't see it on a gram stain. Mycoplasma, Chlamydia, Legionella, viruses, Rickettsia, Lyme disease, Borrelia, none of them are seen on a gram stain because they're intracellular, many of them. So these have a greater spectrum. Now, new fluoroquinolones, levofloxacin, moxifloxacin, gefloxacin, are more effective against penicillin-resistant pneumococcus, but they are not the best initial therapy. Why is amoxicillin considered better than cefuroxime, cefixime, ceftinir, ceftibutin, ceftizoxime, cefdinir? Oh my God, too much information going through my brain. Too much information driving me insane. Why is amoxicillin number one? I got 3 reasons. Because it has the same efficacy as all these others for the initial management of sinusitis and otitis. In other words, these drugs, although microbiologically amoxicillin clavulanic acid combination has a greater spectrum, there's no greater efficacy of amoxicillin clavulanic acid compared to amoxicillin. Although azithromycin, clarithromycin may cover Mycoplasma, Legionella, and Chlamydia, they don't offer any greater efficacy compared to amoxicillin for otitis media. Well, although Levogaddy and Moxi may have better pneumococcal coverage, they don't offer any greater efficacy for otitis and sinusitis. I have another reason for you. You could treat otitis media with anything. You could use chocolate and it will get better 3/4 of the time. Because most otitis media resolves spontaneously. You're only giving the bacterial antibiotics to pick up 10 or 20%. Most of it resolves spontaneously. You're only giving the bacterial antibiotics to pick up an extra 10 or 20%. I'll give you a third reason. That's what the American Academy of Pediatrics says. That's what the practice guidelines are. They say amoxicillin and a decongestant is the best initial therapy. Don't say cost. Yes, it is least expensive. But if it was better, we'd use something else, even if it cost more. Even if it cost more, we would use the other thing. Even if it was more expensive, it was better. You see, it's not that it's less expensive. The cheapest form of healthcare is death. Death is very inexpensive, but it's not more effective. Amoxicillin is the best initial therapy because it has the same efficacy, effect, benefit as the others at less cost. Plus, that's just the way it says. Those are the practice guidelines. Same bugs, same drugs. Now, pharyngitis. Pharyngitis was diagnosed with a sore throat, positive lymph nodes, exudate, sore throat, positive lymph nodes, exudate. In 1941, sore throat, positive lymph nodes, and exudate now. Culture was the most accurate test in 1941, and culture is the most accurate test now. You should look for someone who has the absence of a cough, because remember, cough means you got bronchitis and pneumonia. Cough means you got bronchitis and pneumonia. Cough means you got bronchitis and pneumonia. Cough means it's a lung problem, not pharyngitis. Pharyngitis means Dios mío, doctor, yo tengo dolor aquí, it hurts me. Болит здесь. Помогает мне. Болит здесь. No, if you have pain there, but absence of a cough, cough means that you got a respiratory infection. The other thing is you should have the absence of hoarseness. Absence of hoarseness. Hoarseness means a laryngitis. Hoarseness means a laryngitis. Hoarseness means a laryngitis. Cough and hoarseness means you've got a problem past the level of the pharynx. Pharyngitis, sore throat, positive lymph nodes, exudate on the pharynx. These three things and the absence of these two things give a greater than 90% chance that the culture will be positive for group A beta hemolytic strep. Here is the question. A patient comes to you with a sore throat and positive lymph nodes on physical examination. On examination, you also find an exudate. The patient is most likely to be at risk of developing skin infections, glomerulonephritis, rheumatic fever. Skin infections, glomerulonephritis, or rheumatic fever. Which of the following is the patient most likely to be at risk of? The answer is glomerulonephritis and rheumatic fever both. Remember, pharyngitis can cause you to have both the kidney and the heart. Both the kidney and the heart, rheumatic fever and glomerulonephritis. Skin infections with group A can only give you renal problems. But pharyngitis can give both renal and renal and cardiac. Well, if you have a rapid strep test that's positive, a rapid strep test is positive equals a person who is the same as a culture positive. A positive rapid strep test has the same accuracy as a positive culture for group A beta hemolytic strep. Now, in an adult, a negative rapid strep test is considered the equivalent of a negative test. In a child, do whatever the pediatrician tells you. In a child, you can end up treating and waiting for the results of culture. A positive rapid strep test means definitely treat. A negative rapid strep test in an adult means that it's probably not going to be strep pharyngitis. In a child, it can still be strep pharyngitis. Now, the treatment in 1941 was penicillin. The treatment in the year 2007 is penicillin. Hasn't changed. Same as it ever was. 48-year-old male secretary has got himself a fever and a headache and myalgias and arthralgias, joint pains, feels aches, feels pains, headache, fever, stiff, achy, painy joints. I got a headache, I got a little cough, I feel crampy. Touch me and I'll kill you. Oh, I feel lousy, crampy. Oh, I feel so tired, my head hurts, I just can't get comfortable. I got the flu. What's the therapy? What's the therapy for the flu? Huh? I bet you said like fluids. I bet you said something like supportive therapy. Honey, I still like you when you've got a virus. I mean, influenza virus anyway. The treatment for influenza within the first 48 hours. Within the first 48 hours is oseltamivir and zanamivir. Oseltamivir and zanamivir, oseltamivir and zanamivir, oseltamivir and zanamivir. Amantadine and rimantadine are only good for influenza A. Oseltamivir or zanamivir, these drugs are good for both influenza A and influenza B. Oseltamivir with the IVIR and zanamivir with the IVIR. Oseltamivir and zanamivir are very good right here for the flu. If you feel really crappy and it's only first 2 days, try to put these drugs inside of you. And the reason is they can make 5 days of a crappy experience, but they don't like only 3 or 4 days of a crappy experience. Makes you get better faster. Makes you get better faster. Makes you get better faster. The flu, within the first 2 days, neuraminidase inhibitors, which these are. Pharyngitis, sore throat, positive nodes exudate. Get me a rapid strep test. If it's positive, treat penicillin. Sinusitis, most accurate is a biopsy. Best initial test is an x-ray. What would I do next? I wouldn't bother with any test. I'd go straight to therapy. With what? Amoxicillin, decongestant. The other drugs have broader spectrum, but not necessary. Now let's take a look at some slides looking at these diseases. This is otitis media here, showing you the person who's got a red, bulging tympanic membrane. Look at this, bulging. That's a bulging tympanic membrane. You said, oh my God, look at that's a beach ball in your ear. No, that is a bulging tympanic membrane. Sinusitis. You see this thing here that looks like air and then a fluid, air and then a fluid? You see how it looks here, sort of like an air fluid level? You know what we call it when we see air and fluid and a level there? That's called an air fluid level. Air fluid level, that's sinusitis. Now these are the whole sinuses. The sinus actually comes down to here. The sinus actually comes down to here. This is infected purulent material. Now you know why the most accurate test is a biopsy. Can you look at this and tell me whether you see pneumococcus in there? Do you see the Neisseria? No. X-ray is good. This is an X-ray. CT is better, but the most accurate is a biopsy. Pharyngitis, red pharynx. We don't see much in the way of exudate here. That's why it's a viral pharyngitis. It's a viral pharyngitis because we're not seeing a white exudate. An exudate is a white plaque in the back of the throat. Oh, a little bit like this, except this isn't an exudate, it's an ulcer. It's an ulcer. It's not an exudate. Exudates scrape off, ulcers don't. Wow, there's some exudate. Look at that. Big tonsils, juicy, disgusting exudate. This person has a penicillin deficiency. Well, I'm allergic to penicillin. What would I use? If the allergic reaction is a rash, first-generation cephalosporins. If the allergic reaction is anaphylaxis, then we could use macrolides or clindamycin. Macrolides or clindamycin. Allergic reaction, a rash, cephalosporins. Allergic reaction, anaphylaxis, macrolides or clindamycin. Pharyngitis. Well, this is a picture of the bug influenza, but the most important thing is that it causes aches and pains, myalgias, arthralgias, headache, and mild cough and sore throat. What's the therapy? Within the first 48 hours, neuraminidase inhibitors. Now, physicians hardly ever remember this because they go, influenza ain't going to kill you. Well, listen, oh wise, compassionate healer. It may not kill you, but it makes you uncomfortable. I'll have to remember that the next time you're in a dentist chair. Tell the dentist not to give you any Novocaine, not to give you an anesthetic. Pull his teeth out without anesthetic. Well, and you go, wow, it doesn't kill you, it doesn't kill you. But pain, you know the thing about pain? What's the worst thing about pain? Pain hurts. Therefore, influenza vaccine is what you do to prevent the flu because it keeps you from getting sick and it prevents mortality. Influenza neuraminidase inhibitors make you feel better a day or two faster. Influenza vaccine. Now, what's the difference between this and pneumococcal vaccine? It is above the age of 50. Any chronic heart, lung, liver, kidney cancer. But that's the same as pneumococcal vaccine. Pregnancy, and here's the other big thing. Healthcare workers. You see how we need to be vaccinated against the flu? We are a vector of the flu to our patients. We can transmit the flu to our patients. We don't transmit anything else. We don't transmit pneumococcus. We don't transmit syphilis, but we do transmit influenza. We are the vector. We are the vector. What's the difference between this and pneumococcal vaccine? Pneumococcal vaccine is above the age of 65. This is above the age of 50. Pneumococcal vaccine is not in pregnancy. Pneumococcal vaccine is not in healthcare workers. And pneumococcal vaccine is not yearly. It's one single injection at the age of 65. Maybe one booster 5 years later. The flu vaccine is every year. Flu vaccine yearly, above 50, or healthcare workers every year. That's the end of our head and neck section. See you in the next section.